we host our Health Councils talk twice a month, giving a chance for presenters, resources, information sharing, presentations statewide from different resources or state agencies. Just an opportunity for health councils to connect to other resources, possibly outside or inside their community, giving space for that, and obviously questions. And today we will be having Athena from Ideal Option, and her topic is going to be around Xylazine, specifically a new method for testing for Xylazine and standard drug testing panel. And so if you get a chance, please introduce yourself in the chat, name, health council, or possibly the organization that you are from. And I'm going to go ahead and move forward here with our slide deck. I just want to share one very quick special announcement. If you can go to the next slide deck. Awesome. Okay, so before we kick it off into our special announcement, I'm going to give the chance to Hasia to read our land acknowledgement before we get started in our Health Council talks. Apologies.
So sorry about that. The New Mexico Alliance of Health Councils humbly recognizes and acknowledges we are on unceded territory and ancestral lands of the original peoples of New Mexico Pueblos, Apache Nations, and the Navajo Nation. Together, we acknowledge the history of genocide, dispossession, colonization, ongoing systemic inequities, while strengthening and respecting relationships with Indigenous peoples. We give thanks to the past, present, and future stewards of this land and respect all tribal nations' sovereignty. In offering this land acknowledgement, we affirm Indigenous resiliency, self-determination, and self-governance of New Mexico's tribes, pueblos, and nations who are still here today. Thank you.
Thank you so much, Hasia, for taking the time to read our land acknowledgement and giving some space for that very early in our Health Council's talk. And so on to our special advocacy announcement. Very quickly, just before we get into our presentation and giving time for Athena, we have some really great news from the Alliance to share with you all. And I think most of our health councils have already received this announcement. But as part of our House Bill 67 efforts and outreach, NMHC staff were able to enlist the strong support from House Appropriations and Legislative Finance, who then worked with NMDOH's leadership to increase the state funding for the traditional, the DOH traditional funds for health councils. What health councils were receiving in the current funding year was $648,000 to what will now be $3 million. So I just want to give a very quick shout out and let people know that our advocacy and outreach efforts are working. And yeah, I don't know. I'm super excited. This has been 13 years in the making, and very appreciative of our leadership from Representative Allison. If you all get a chance to hear him in public comment and stand up to some of his colleagues in these meetings on behalf of health councils, he has been a strong advocate. I know our House Bill 67 we are advocating for 6.6 million. So we are currently at 3 million now. I know the session is not over, so our plans now are to list Senate Finance for them to provide health councils with the remaining 3 million. And so yes, it's just want to share this wonderful news before we get started into our presentation. If you have any questions or want to get involved with some of the work, please reach out to me. I'm more than happy to be of a support for that. So yes, and now I will kick it off to you, Athena, for your presentation, and we look forward to learning more about Xylazine and some of the testing efforts that you would like to share with us. So I'll kick it off to you.
Thanks so much. I appreciate that. I'm so grateful to be here. Thanks, everybody. It's so nice to see, so many familiar faces. And Geraldine, I thank you for making this happen. It's great to see folks like Holly and, Brenda Bishop and Pamela Skinner and, people that I haven't seen in a while. So thanks for being on the meeting. Um, so I'm wondering if we can transfer and I can share my screen.
Yes, we will stop share here in a second. Apologies.
No worries.
There we go.
Great. And then, perfect. And then can you guys see this presentation here?
Yes.
Okay, I'm going to move it into slideshow view. So hopefully that will work as well. Great.
Yes.
Okay. So, and I apologize if there was any miscommunication. The email that was sent out was about Ideal Option, who I work for full time. Ideal Option is a low barrier medication assisted treatment clinic here in the state, and our efforts to standardize xylazine testing in our regular drug panel. However, that's not something that's really available to other programs, right? Unless they also have their own mass spectrometers and lab and availability to test for this. There's xylazine test strips, but xylazine is not something that most places are testing for, which is why we were excited to announce about it. My presentation is really more geared towards xylazine myths and xylazine facts so that we can sort of separate the wheat from the chaff, right? When these reports of xylazine in our communities are coming forward. So I hope that will still be interesting to the council. And please feel free, because of the Zoom view, if you have a question as I'm going along, if you raise your hand, it pops you to the top and I'll know you have a question and I can see you and address it. The chat is a little hard to see at the time that I'm presenting. So please feel free to jump in. I'd love to, answer questions about this as we go along. So xylazine, I think it's important to kind of understand the history of this drug. So xylazine was originally developed in the 1960s to treat hypertension in humans, but they ended up not using it for this purpose because it has a pretty pronounced sedative effect. So it was abandoned for use in humans, but I think it's important to know that it was developed originally for use in humans. So I think when people hear about xylazine, one of the first things they may hear is that it's an animal tranquilizer or a horse tranquilizer. And that is somewhat true, and that's what it's used for now, but that's not what the drug was developed for originally. So I think that is important. It was developed for use in humans, but then abandoned. So today it is routinely used as a tranquilizer in animal medicine. So as a surgical anesthetic and a sedative in veterinary medicine. It's generally packaged as an injectable solution and it's sold under several different brand names. And it is not regulated, right? Regulated, it's regulated. It's not scheduled, meaning that it's not, considered uh, it's not something that somebody has to have a DEA license to prescribe or to obtain. It's pretty easy to get on like a veterinary supply website, let's say. I think that another thing to note about the history of xylazine is people think that this is like very new, right? Either that it's a new drug, which is not correct. It's been around since the 1960s, or that we're, seeing it in the drug supply is new. And this is also incorrect. Xylazine has been detected intermittently in the North American unregulated drug supply for years. And it's especially noted, sorry, I didn't mean to skip ahead. It's especially noted in the drug supply, for example, in Puerto Rico. So our Puerto Rican counterparts have been dealing with this in the drug supply for a long time. Poisonings from xylazine have been noted as early as the 70s and 80s. And are, important also to note that our Puerto Rican counterparts are the first ones that identified the skin lesions that somehow sometimes come along with xylazine. And that in Puerto Rico, it was mostly found, or is mostly found, alongside heroin and cocaine. So I think history is important, right? To know where things come from and how they were developed, and what the history of something is great. Any questions on this as far as the history of xylazine before I move on? Okay, so the current status of xylazine is that it's becoming increasingly prevalent, and has become increasingly prevalent, in the North American unregulated opioid supply in recent years. Also important to note that this increase is probably underestimated. The reasons are because of this lack of testing. Xylazine is not tested for routinely in postmortem toxicology. So, like when somebody dies of a suspected overdose, it's not routinely looked at to see if there's xylazine in the system. And vital statistics data, even if it is detected, doesn't have a specific and distinct code to identify xylazine. So, xylazine wouldn't necessarily be noted on a death certificate using a diagnosis code, even if it is detected. And it's unclear whether this increase in the drug supply, in the unregulated drug supply, if the xylazine is coming from the veterinary pharmaceutical supply, right? Meaning that people are ordering this online from veterinary websites, or if it's being synthesized locally. And it's also important to note that xylazine is sold and can be purchased on the Chinese research chemical marketplace, which may be another source of where the xylazine in the North American unregulated drug supply is coming from. Any questions on this slide before I move on? Sorry, I know I'm using like a lot of, there's some jargon in this, and I just want to make sure people are understanding, and so please feel free to stop me. So the question that we're having is, why now? So why is xylazine in the drug supply now, in the North American unregulated drug supply? And there are conflicting theories about why xylazine has been introduced into the street supply. Many people, people who use drugs, report that they don't want it in their supply, and it's not something that they enjoy. So, why would we want to? Why would the cartels, right, or people that are supplying, we could call them drug dealers, why would they want to hamper their sales? And we're unclear if xylazine is being sold as a pre-mixed cut. There's also regional variation to the way the xylazine is processed and sold. So we're finding it in the drug supply as a primary ingredient in some street samples, but then it's also being found in trace quantities. So those indicate different reasons, right, for introducing xylazine into the supply. It may be that it's just being used as a bulking agent, and they're using xylazine intentionally. But, if you think, for example, of the blue pills that are most frequently being used right now as far as the fentanyl supply, that 99% of that pill is not fentanyl. And so fentanyl is measured in micrograms. It's a very tiny amount of fentanyl, and the rest is bulking agent. So, is it being used for that purpose? Xylazine's sedative properties also allow for less fentanyl in the mix, which may have the goal of inducing less respiratory. Sorry, hi. Luz, did you have a question?
No.
Okay, you're unmuted. Thank you. So xylazine sedative properties allow for less fentanyl in the mix, and it may be that there's a goal of inducing less respiratory depression due to fentanyl. Also important to note that xylazine is chemically very similar to things like clonidine and lofexidine, both of which are used to treat opioid withdrawal. So xylazine might be intentionally being introduced to the mix to treat withdrawal symptoms between opioid doses. So again, nobody's really sure why xylazine is showing up in such quantities in the drug supply now, and it could be for any of these reasons. Does anybody sort of have questions on this before we skip to the next slide? Okay. So xylazine in the unregulated drug supply causes three main harms. Those harms are acute poisoning, prolonged sedation, and skin wounds. Number one, we're going to talk about the first harm, acute poisoning. So xylazine, again, because of its sedative effects, reduces the level of consciousness and lowers heart rate and blood pressure. Human case reports have identified a decreased respiratory rate and the need for mechanical intervention when very high doses of xylazine are administered. So mechanical, right, we mean like a ventilator or something of that nature. At the same time, reported fatalities from xylazine alone are extremely rare. And I think it's really important to note that even though xylazine is being introduced into the drug supply, there's this sort of rhetoric that's going around. Even Ideal Option, right, tried to make a webinar saying xylazine is making the deadly drug epidemic even deadlier. But actually, if we look at the data, the drug epidemic is still really being driven by fentanyl, regardless that xylazine is being added. Xylazine is not like statistically significant, right, in driving overdose deaths because it's pretty rare to be able to overdose on xylazine. So as this next point points out, illicitly manufactured fentanyls were present in 98.4% of xylazine involved poisonings from 2015 to 2020 in the United States. So of the overdoses that involved xylazine, 98.4% also included fentanyl. So what we really see is it's still the fentanyl, as much as we want to say other things being introduced are causing deaths. And fentanyls are the primary drivers of respiratory depression and death. The message that we want to take away here, contrary to the message that we're hearing a lot, one of the messages that I have seen coming out is now that there's xylazine in the drug supply, we don't need to be utilizing Narcan because Narcan doesn't work on xylazine. This is incorrect. Naloxone remains a critical tool for anyone who may experience or respond to a drug poisoning because, again, fentanyl is what's driving the deaths. So clinicians have to recognize also that chronic exposure to xylazine can complicate withdrawal management in patients with opioid use disorder. So we're learning more and more, about xylazine and how it works in the body. Like we had said in the first slide, we sort of stopped studying it in humans in the 1960s. So we're having to pick it up and study it again. One of the things that's looking to be true is that xylazine affects one of the opioid receptors, the kappa receptor. Buprenorphine, for example, is a weak kappa agonist. So it doesn't do much for people in xylazine withdrawal because it's affecting the kappa receptor and buprenorphine isn't able to fill that receptor. So methadone, for example, may be a better choice for people that are experiencing xylazine in the fentanyl supply. And there may be other medications that are needed to help people with their withdrawal when they have xylazine in their fentanyl. Any questions on this? This was a little complicated, so I want to make sure people are clear. Sorry, and I'm going to look at the chat too to see if.
Oh, Athena, I do have a question. Is there statistics specifically for New Mexico around the acute poisoning for xylazine?
No, this is the proportion of poisoning deaths in the USA.
Okay.
Yeah, so this is not nationwide data.
Awesome. Is there any data specifically for New Mexico that health councils can look for their counties or?
No, so xylazine, in order to look at that, somebody would have to pull a data set from OEM and see if they've even been accounting for xylazine. Because this is so new, it's not something that's showing up in our death report data, and it's something that a researcher would have to look into and pull original toxicology reports and see what was founded and if it was even tested for.
Thank you. And very quickly, what is OEM?
Oh, sorry, I don't even know what it stands for. It's the death, sorry, I'll look it up. Does anybody know before OEM is Office of Emergency Management, and I think I'm using the wrong acronym, actually. I'm thinking about the office that deals with the toxicology deaths in the state.
Oh,
The OMI, Office of
OMI,
Medical Investigator.
Office of the Medical Investigator. Thank you.
Awesome. Thank you.
That's the danger in using acronyms too much, right? Then we mess up the acronym and it's not even the right one. Thanks for that question. I appreciate that. Let's see if I can get the slide deck to advance. Okay, xylazine harm number 2 is that xylazine can cause prolonged sedation. So one of the things that's been reported is extended periods of sedation and immobility. We've always noted with people using opioids that nodding is a well-known effect, but sedation with xylazine appears distinctive. The sedation that's experienced with people using xylazine is lengthier, and it's associated with long periods of immobility. And so people will end up in weird positions and sort of get the blood flow cut off maybe to that limb, and that can cause injury. So one of the things that we advocate when working in the community with people that are using xylazine is things like padding, turning people, laying people on flat surfaces, avoiding skin friction while moving or turning, and making sure that their skin remains dry. So basically that if you're like intervening with somebody in the community who has this sedation effect due to xylazine, knowing that leaving them in an awkward position for a long period of time could affect the health of a limb, right? Or could cause, excessive bruising or other injury. So we also suggest that moving people who have nodded in awkward positions onto their side should be encouraged. So this is also in the case of, somebody who's breathing well, right? Like they're breathing, 5 to 10 breaths a minute and are not experiencing respiratory depression. Obviously, if somebody is experiencing respiratory depression, we want to administer Narcan and call 911, right? We're talking about, they're breathing fine, their color's fine, they're just heavily sedated. So we want to move them if needed. We also want to be vigilant for other harms like sexual assault, physical assault, and theft. Especially while our unhoused and unsheltered relatives, right? They may pass out in an awkward position and then may be subject to one of these things. This isn't new though. We see this type of sedation also with alcohol use, right? And alcohol has long been known to be associated with sexual assault, physical assault, and theft. So very similar to alcohol in that way. And then, of course, again, for our unsheltered neighbors, sedation outdoors poses a heightened risk for injury if occurring on or near streets, sidewalks, or train tracks, right? We don't want people to be in danger of being injured by something traveling by. And then the third harm, and I think the one that's like most in the media and most sensationalized, are the skin wounds. So it's important to know that the presentation of skin wounds attributed to xylazine exposure are distinct. And what makes them distinct is that they are not like injection abscesses, right? They emerge at sites other than those used for injection and can even emerge if the person does not inject at all, right? So somebody could be smoking the blue pills. Those pills have some xylazine in them. The person is utilizing xylazine over a period of time, and then they may develop skin lesions, even though they're not injecting. They are distinctive in that they are generally large, they're granular, and they're burn-like, and they appear severe. So people get really, somebody shows up at a hospital for wound care with this type of wound, and it sort of galvanizes people, right? It looks very bad. So it's important to note that though the wounds are dramatic looking, they do often respond very well to treatment. And so just going over and understanding appropriate wound care and thinking about, as far as like our health councils and working with organizations that are working with people using opioids, Advocating for things like wound care kits being added to street outreach bags, that harm reduction programs pass out also wound care supplies, as well as the other supplies that they're passing out. So appropriate wound care is that we want to assess the wound in the affected area. You want to cleanse the wound with soap and water, a specific wound cleanser or a saline solution. We don't want to use, for example, hydrogen peroxide or alcohol or, something crazy, right? We want to just use, soap and water is really great. Prepare supplies with ointments, right? Like maybe triple antibiotic ointment, other types of ointments, and a debriding agent if that's indicated. A debriding agent would be more like prescribed by a doctor or, at a wound care clinic. And then we want to dress the wound. So, cleanse with soap and water, put some triple antibiotic ointment on it, and cover the wound. And then we also want to advocate that people should not use hydrogen peroxide on these wounds. And something to think about, again, as health councils, right? And thinking about things like academic detailing and stigma reduction. For people who use drugs, a major barrier to seeking medical attention is maltreatment in the medical setting. People would rather die than go to the ER and be stigmatized for their drug use. Literally, it happens all the time in our communities. This is particularly true for people seeking wound care. So, educating our community partners and our community about non-stigmatizing care for people using drugs is so important so that people feel comfortable to get the care that's needed for wounds if needed. So any questions on these with the xylazine wounds? I think people are hearing a lot about this and there's a lot of concern.
Yes, Athena, there's a question in the chat from Janice. What is the issue with hydrogen peroxide?
Hydrogen peroxide, contrary to popular belief, doesn't just kill uh, wounded tissue, it also kills healthy tissue. So hydrogen peroxide is overkill, and so it's actually not really recommended in wound care at all these days. But especially because the xylazine wounds are large, you would be applying hydrogen peroxide to a large swath of the body, and so that would be killing off also healthy tissue that's present. Does that make sense?
Yes, thank you.
Yes, absolutely. So actions we can take. Again, I just want to try to get this message out as much as possible because I see the opposite message so much and it's so harmful. This idea that, we don't need Narcan anymore because it doesn't even work on xylazine is so uninformed and misapplied. Naloxone saturation is actually more important than ever. And we may want to add to our trainings educating about prolonged sedation with xylazine and emphasizing rescue breathing as part of the intervention. So, we can add a little bit to these trainings, but, naloxone is more important than ever and absolutely should be used anytime that anybody has respiratory depression and there may be a suspected overdose. Don't get in the weeds about whether xylazine is present or not. It really is not going to affect the response other than, if the person resumes breathing well and is in an awkward position, you want to move them, right? So that they're no longer in that awkward position. But you're still going to call 911. You're still going to administer Narcan. You're still going to administer rescue breaths. Like it doesn't change. Along with naloxone, we would like to see wound kits made easily and widely available to people that use drugs, and information about how to care for wounds properly. Access to methadone as well as adjunctive medications with buprenorphine treatment will be important to eliminate withdrawal and cravings and stabilize individuals on MAT. So again, that access to evidence-based FDA-approved medications to treat opioid use disorder is more important than ever. The other thing that's important is to eliminate stigma among medical practitioners. I know Holly works on this, at the residency program when she works with them at Alamogordo. We have a big problem in New Mexico and nationwide that 60% of inpatient facilities that take Medicaid don't allow the FDA approved medications to treat opioid use disorder, right? They're based on an abstinence only model that is not evidence based. That's a big problem and does a disservice in our communities. Skilled nursing facilities are important for wound care, and the skilled nursing facilities in New Mexico at this time still do not allow the FDA approved medications for opioid use disorder. Disability Rights New Mexico is bringing a lawsuit forward about this, and lawsuits have been filed in many other states that experience this problem. But, skilled nursing facilities administer full agonist opioids all the time. So, I don't understand the reason that they don't want to administer these medications like buprenorphine, which is a partial agonist opioid. And then finally, eliminating stigma among hospitals and emergency departments so that people feel comfortable going in and to get their wounds addressed, to get their opioid use disorder addressed, and to be connected to correct care. So these are all actions that we can take as health councils to try to move the needle on all of this. Any questions on this slide or anything that I've covered so far? I realized I started rattling through things really fast. That's really all I've got. So unless we want to have, a more robust discussion, that's what I have as far as my presentation. So the information on this deck was pulled from the following: Zagorski et al., Reducing the Clinical Harms of Xylazine, Reducing the Harms of Xylazine, Clinical Approaches, Deficits, Public Health Context. So you can read this in the Harm Reduction Journal, came out this year. I had an opportunity to meet the researchers when I was at the Drug Policy Alliance conference in Phoenix last year, and there are additional citations that I, noted in the deck. Many additional thanks to Philip Feudy and Nabarun Dasgupta, who is one of the original researchers that's working on xylazine. He's at University of North Carolina, Chapel Hill. So, and I'd love to answer. This is my contact information if you don't have it and would like to get in touch with me. My official title is that I'm the Community Outreach Manager for Ideal Option for the state of New Mexico. Again, Ideal Option is a low barrier medication assisted treatment clinic. Here's my phone number. It's my work phone and my email. Please feel free to take that down. I can also send the presentation to Geraldine so that you can send it out to everybody. And I would love to answer more questions on this. And then just reiterating, Ideal Option we're based in Washington, and we have our own labs in Kennewick, Washington, where we have one time of flight mass spectrometer and several other mass spectrometers, and we have added xylazine to our routine drug testing panel. So hopefully by the end of the first quarter of 2024, Geraldine, speaking to your question, we should have local data that we can share about xylazine and its prevalence in New Mexico. I can tell you that we have, had xylazine show up in all the communities we serve in New Mexico, but not in a widespread way, right? A positive test here, a positive test there, one in Farmington, one in Las Cruces, a couple in Albuquerque, sort of like a scattershot pattern, right? Nothing showing that xylazine is widely available in the illicit drug supply in New Mexico. So just want to throw that out there, that's like what the preliminary data is sort of showing. And we will release that at the end of the quarter when our drug test results, when we actually have some power to our data and can present something that's helpful.
Athena, I did have a question. Is this the drug that Narcan doesn't work on, or they can use Narcan?
So I'm just going to go back to the slide deck on this, just because I do really want to emphasize this point, and I have emphasized it a few times throughout the presentation. So oh, sorry, let me find the Dang it, I saw it. Hold on one second. Here we go. Okay, so just to go over this again, xylazine is not an opioid. However, from 2015 to 2020, 98.4% of xylazine involved poisonings involved fentanyl. And I really want to emphasize that fentanyl is still, even in places where xylazine is widely available in the drug supply, the primary driver of respiratory depression and death, right? So the thing causing the respiratory depression and death is the fentanyl, not the xylazine. And fentanyl absolutely is responsive to naloxone. And so one of the things that I really, again, want to emphasize is that contrary to the message that we're hearing that xylazine, right, that naloxone doesn't work on xylazine, or that Narcan is, xylazine is Narcan resistant or something like that, right? Number one, we're seeing some evidence that xylazine activates the kappa opioid receptor, so that there may actually be some opioid-like activity with xylazine. So this statement that it's Narcan resistant, right, is really not, we don't even know fully, exactly how xylazine works in the body. And so second of all, I want to emphasize that naloxone saturation is more important than ever. So this line goes around that like naloxone doesn't work on xylazine, but fentanyl is what's driving the death. So naloxone response is actually more important than ever. So I just want to make that statement and make that really clear. And I hope that's clear and helpful.
Thank you for
Yeah.
reiterating that. Thank you.
Yeah, absolutely. I just feel like that message keeps going around, and I hear it all the time, right? Xylazine is Narcan resistant. And I'm like, number one, we don't know that for sure. There may be some evidence that that naloxone works at that kappa receptor to dislodge the xylazine, and more research is needed. So yeah, just I don't think that's actually a true statement.
Yeah, that's what I tell my clients. It might not wake them up, but it'll keep them from dying.
Exactly. That's a great way to say it. Perfect. Janice?
Yeah, I was just going to remark along the same lines that, from my understanding, the primary difference with a Narcan reversal where xylazine is involved is that the person may start breathing but not regain consciousness. So as you're giving those rescue breaths, you really need to pay attention to see if their breathing has independently resumed, and then put them into rescue position on their side if they do resume breathing but are non-responsive, so that in case if they do vomit, they're in a safe spot, and then just wait for help to arrive and continue to monitor.
That's, yes, absolutely. Sorry, I'm just like reviewing the chat and seeing if I missed anything there. Also, just to point it out, I keep using the correct terminology, right? Xylazine. You also may have heard this referred to as tranq. And you may have referred, I really hate this term. I hesitate to even say it out loud because I think it's so stigmatizing, but it is referred to sometimes as the zombie drug, which I hate. I don't like referring to our community members as zombies. I think it's really awful and stigmatizing. I'd love to hear other questions, other thoughts, other things that you'd like to share, things you're hearing in your community that may or may not be true about xylazine.
I have a question in regards to areas where it is prevalent.
Okay.
Are there indications for treatment in that case that are different? In other words, like, is the withdrawal process different, or what does that look
Yeah, so one of the things that we're, so ideal option, for example, I wish I had this information ready for you. I can definitely circle back with it as to exactly what we have changed, but we have changed our medication protocols when we're inducting people onto buprenorphine. like number one with fentanyl, it's important to give a lot of comfort meds along with the buprenorphine. So we give people anti-nausea meds, you know, and other medications to sort of help ease them along. One of the things that we're seeing that I also mentioned is that for people that have a lot of xylazine in the drug supply, methadone works much better than buprenorphine. So this is one of the reasons why I feel like we all have to advocate to expand access to methadone. It just works better in this case, right? Maybe because methadone is active at the kappa agonist, at the kappa opioid receptor. Maybe that's the key. There's also some speculation that xylazine acts a little bit more like a benzo in the body. So some organizations are doing like a benzodiazepine taper. Gabriella, I see you on the call. Do you have any, sorry, I don't mean to call you out at all if you don't have this, but you know, at the Southwest Pathways program at DOH, are you guys offering different medications?
No, currently it's just the buprenorphine. It's the
Okay.
Suboxone.
Okay. So yeah, it basically like depends on the program and, you know, but yes, there are different, what about Vivitrol or Sublocade? So Vivitrol is an opioid blocker. Somebody has to be completely off of all opioid based and other medications for a period of 14 days. Vivitrol is also not a first line medication for opioid use disorder. Um, buprenorphine and methadone are the recommended. And then if that doesn't work, you know, Vivitrol can be tried. But again, they have to be off of all opioid medications for 14 days, 2 weeks before they can be started on a Vivitrol injection. So, I mean, most of our community members using fentanyl can't stop using for even a couple of hours. So asking somebody to stop using for 14 days is just not something that most of our community members can do. That being said, you know, I do know of a couple of people that have been very successful with Vivitrol. Maybe they went through like, you know, more of like an abstinence only or a weaning process inpatient, and then were able to be transitioned to Vivitrol. We don't really have that available here in New Mexico as something that somebody that you know, people are doing. And Sublocade is a great option. However, other than like, I know of a tribal doctor in Alaska that's doing Sublocade injections as like a first line, but it's tricky. And so for most people, you have to do oral buprenorphine first, get them stabilized on that oral dose, and then transition them to Sublocade. And it's important to remember that Sublocade is buprenorphine, but injectable. So if their cravings aren't being controlled by buprenorphine, they're not necessarily going to be controlled by Sublocade either. It's the same drug, it's just in a different formulation. Does that make sense or help?
That was so extremely informative. Thank you.
Absolutely. Thanks, Maureen. That's really kind. I appreciate you. I'm just going to read this. Mary says, specifically identifying skin wounds. I encountered an individual with these types of wounds by conducting pit count. Having wound kits is a great suggestion as we are out in the community. Yeah, I think it's really important. I think people get, one of the things that happened in Puerto Rico, you know, when it was first showing up in the drug supply, like in the 80s, 70s and 80s, was the wounds are so dramatic that sometimes they would amputate. You know, and so then you had all these folks in Puerto Rico that were using drugs that were missing arms and, you know, lower parts of legs and things. But it's important to know that these wounds look really dramatic, but they respond really well to treatment. So we want to avoid, you know, doing things like amputations, right, when we could be treating the wound. Yeah, definitely suggesting that for next year's pit count is a great idea. I'm really trying to include the wound care kits along with like my hygiene bags and Narcan kits and all the rest of the stuff I have when I'm running around town. Great, I love that. In Eddy County, they're partnering with the public library to create a foot wound care program. That's probably super helpful for your diabetic folks too. And you know, some diabetic folks are also people that use drugs, so it probably makes their feet, you know, even more vulnerable to developing these types of skin lesions. That's a good question. Where to get funding or donations for wound kit supplies? We should ask Department of Health's harm reduction program whether that's something that they are offering. I know that people can get signed up to order supplies through Department of Health, and that might be somewhere that would be available. So that would be who I would check with first. I also have, if you would like, and you could certainly, change it for your own needs, and I can send that to Geraldine along with the presentation. Like, it's like a little pamphlet for folks that gives the wound care instructions, so that you could add that to the kits. And I think that was developed by a program in Canada, but happy to distribute it, and you could, change it for your own needs in your communities. Okay, well, if there's no questions, I thought people were gonna like really nail me to the wall with questions, but it seems like we have 10 minutes left. I'm happy to give people 10 minutes back of their day, or Geraldine, if you have more things to cover in your agenda.
Thank you, Athena. Yes, we will share your slide deck, and if any questions come up, we'll be sure to keep your contact information on the announcement that we send out. And if we still have 36 people on here, I want to be sure if we could get a chance to hear from Valeria, our executive director, on advocacy efforts. And if anybody has any questions at this time, we would spend some 10 minutes, talking about any updates or questions around advocacy efforts at this time. Okay, Mila.